their true thoughts about the matter and what their true opinions are. So our first topic for debate is individuals over 75 years old. Should they continue to be screened for colorectal cancer? And taking the yes for this will be Dr. Ladabaum. Those mics work? Okay.
Wow, well, I'm super honored by the robe. That was a little throwaway line on an email, like, I get a robe? And look, I got a robe. So that's awesome. Yeah, exactly. That's amazing. Thanks a lot. So as you heard, the views expressed by the speakers may or may not be the views of the speakers, but here we go. So the key arguments to continue screening or to start screening at that age, if you haven't been screened. Colorectal cancer incidence is highest at ages 75. If you look at the curves, then you look at the ages up here, the highest yield, if you were to say, I'm going to screen you, is in older people. And when we're talking about screening for colorectal cancer, we'll talk about precancer in a moment, colorectal cancer, you're talking about people who are walking around with colorectal cancer without knowing it, just like the Beatles here crossing Abbey Road. Now, you can also find advanced precancerous lesions, as you know, advanced adenomas, and the rate of finding them goes up with age. These are our data from Stanford, first-time screening colonoscopies. The yield for these potentially important lesions goes up with age at first screen. And you might say, well, but we're talking in many cases about continuing to screen people, not first-time screen. Well, even in the non-first-time screening, the yield goes up with age. And in the upper 70s, it's similar to what it is in the 50s for first-time screen. So if people have enough lifetime ahead of them, it's worth doing. Now, that's a key point. There's still substantial quantity of life left for many people and quality of life. And if you look at the expectation of life by age, the quantity of life based on US life tables, people who are 75 or 76, they've made it that far. They have an expectation of life of about 12 years. If you make it to your early 80s, expectation of life about 9 years, and even in the early 80s, 6.7 years. Now, on top of that, you can thrive. Some of these people are famous, some of them are not. Think about your own relatives. What would you say to them if they're still doing great and you're talking about a preventive intervention? Now, if you're thinking, oh my God, do I want a colonoscope? My 79-year-old neighbor, there is non-invasive screening. That is possible. You don't always have to worry about the risk of colonoscopy. If you wish for alternatives, you might find papers like this, Systematic Review and Meta-Analysis of the FIT test. And look who the author is, Jeffrey Lee, who's going to tell you maybe other things in this talk here. Sensitivity for colorectal cancer, one around 79%, and programmatic yield is going to be higher. Now, what about screening those who have never been screened? This is an absolute no-brainer. This has been well studied in terms of yield and also even in the potential cost effectiveness. If you're an elderly person who've never been screened, it is cost effective to screen you on average through age 86. So slam dunk there. And then finally, the USPSTF says, selectively do this. So Jeff's going to come up here and argue against the USPSTF. Remember that. So we have all these key points, and there's a USPSTF recommendation, and Jeff Lee's going to say no. Now, some years ago, you may remember, this was a big splash. Zeke Emanuel said, I wish I die at 75. And I'll read you what he said here. His also inspired philosophy is this: at 75 and beyond, I will need a good reason to even visit the doctor and take any medical test or treatment, no matter how routine. That good reason is not it'll prolong your life. I'll stop getting any regular preventive tests, screening, or interventions. I'll accept only palliative, et cetera, et cetera. They asked him 5 years later, what do you think? He was even more wrong. Oh, these people living a vigorous life, 70, 80, 90, the slide I show you. When I look at what they, quote, do, it's play. It's not meaningful work. They're riding motorcycles, they're hiking. Okay, that can all have value, don't get me wrong. But if it's the main thing in your life, that's probably not a meaningful life. So Jeff Lee believes Zeke Emanuel is right. He does not care about colorectal cancer screening after 75. He doesn't even care if the two remaining alive Beatles, Paul or Ringo, die of colorectal cancer. They're 79, 81. If they came to Jeff and said, Dr. Lee, please screen me, he'd say, no soup for you, next. And you Seinfeld fans hopefully get this. So vote Ladabaum for round one knockdown champion. I'm Yuri Ladabaum and I approve this message.
Yeah, it's hard to dethrone the three-time champ. Thank you, Serge, and the planning committee for letting a community doc like myself battle against the vice chief of GI. So let me advance the slides. Hopefully, as community docs, it's hard to play with PowerPoint. All right. See, can't even advance it. Yeah, it's rigged. This one. All right, my argument is we shouldn't screen for individuals older than 75. Here are the reasons. Well, here's my disclosures So currently there's no randomized control trials that have shown that screening is actually effective in this age group. Here in the slide, we summarize all the randomized control trials for screening tests, FOBT, sigmoidoscopy, and we have two trials that are undergoing right now, colonoscopy versus FIT, and none of them actually include the older age group. So no trials have ever demonstrated screening effectiveness in this group. So if we don't have any randomized trials, we have to rely on observational studies. Now, what do we have from the data in terms of observational studies? So here is a study out of the Harvard group, and what they emulated a randomized trial using observational data set from Medicare beneficiaries of over 1.3 million individuals. And what they saw was that there's barely any benefit if you underwent a screening colonoscopy 75 to 79 years of age. And this is with 8 years of follow-up. And so you could see that the absolute risk if you underwent a screening colonoscopy was about 2.84% for colorectal cancer death, compared to 2.97% if you did not receive any screening. Now, another new study that just was published last year in JAMA Oncology, also from the Harvard group, studying among nurses and physicians from their cohort, they were able to demonstrate that the relative risk, or the risk of dying from colorectal cancer, was reduced by 40% if you underwent screening after age 75. Now, relative risk is a very powerful tool to be able to help demonstrate that, yeah, there is some effectiveness. But if you look at the absolute risk and you were able to calculate it, and this was actually in the commentary and not in the paper itself, what you find is that the absolute risk of dying from colorectal cancer, if you were unscreened, was about 0.59%, compared to if you underwent screening colonoscopy at 0.53%. So the absolute risk difference is incredibly small. So pretty much very little benefit. And not only that, if you look at the subgroup analysis from the same paper, although there was no significant interaction, what you find was that screening was only beneficial among healthy individuals, those without cardiovascular disease and those without any comorbidities. Now, what Yuri failed to mention is that there are some potential consequences and harms associated with colonoscopy. The risk of perforation clearly goes up with age, here in the systematic review and meta-analysis from Luke John Day and his group. We also see that the risk of cardiovascular events actually increases with age. And this is from the Harvard study that emulated that randomized trial. We see a twofold increased risk of cardiovascular events with age as you progress into the 75 to 79 years group. Not only do you have more perforation, but cardiovascular events, you also have unplanned emergency department visits, hospitalizations. Those increase with age too, nearly 2.3-fold compared to those with individuals that were less than 74 years of age. So you can see this linear increase as you continue to advance in age. Not only that, our esteemed vice chief wanted to continue exploring about complications. And what he was able to find was that, yes, risk of perforation is pretty low compared to the baseline background rate of individuals that underwent compared to the controls, not non-colonoscopy controls in California. And so you could see in this abstract, or in the title, there's low rates of GI and non-GI complications. But if you look buried in the last figure of his paper, you can see a 3 to 5-fold increased risk among those who are 70 to 79 and those 80 to 80 years over 80 years old who underwent a screening colonoscopy compared to those 50 to 59. And these complications were for cardiovascular events and even cerebrovascular events such as stroke and TIAs. So Yuri also looked into this a little more in depth in 3 different states, in California, Texas, and New York, and looked at the baseline excess risk of complications, particularly non-GI complications. And what we found was that yes, you're having a higher risk of perforation, lower GI bleed complete compared to non-colonoscopy controls, but you also find other important non-GI events like cardiac arrhythmias, CHF, ischemic stroke. And what you could see is that there's clearly an increased risk or twofold observed rate compared to the expected rate in this cohort. And what you see in his quote, as he quotes, "It is sobering that serious non-GI complications associated with colonoscopy predominating over GI complications after age 65. So even our vice chief acknowledges that serious non-GI complications increases with age. I also want to mention that as you age, you also have issues with the bowel prep. This is pretty clear. And then this is a study that Yuri was able to mention earlier. Is colorectal cancer screening effective or cost effective in older adults? He argued yes, but I would like to point out that there are many assumptions with models. Number one, it assumes no prior screening in the US and for this particular study. And we know that's incredibly rare in the US. In fact, over 80% have undergone, or 60 to 70 to 80% have undergone screening in the US. It also assumes that colonoscopy effectiveness is quite effective in this age group. And they assume that 12 deaths prevented per 1,000 screened. But based on that Harvard study, the number needed to treat to prevent 1 death was actually 1 in 1,600. So this assumption is clearly wrong. It also assumes a high quality colonoscopy. And we know from many university-based studies, including Stanford, there's wide variability in ADRs. We also see some complication rates are based only on colonoscopies with polypectomy. And we clearly see that on the prior slides that colonoscopy complication rates continue to increase even without polypectomy. So back to this slide that Yuri was able to show. I just want to summarize that the evidence indicates that the net benefit of screening on the 3rd line for all persons in this age group is small, and I would argue it's incredibly small. So last thing, it's not a slam dunk for this age group. We currently lack, screening effectiveness studies. We don't have the evidence, the strong enough evidence, because current observational studies have selection biases and confounding. We also lack studies using overall mortality and colorectal cancer mortality as the primary endpoint. We also lack studies that include competing risk of death. And lastly, our models are based on these assumptions, and we clearly need to update those models with some of the recent data to really show, is it truly cost effective or not?
Okay. Great job, Jeff. All right. Screening colonoscopy. I think we're going to do these in the other order, but it showed up like this. So I'm going to argue that it is going, and soon gone. We've been hearing this for a long time, but it's finally happening. We have developed tunnel vision as a specialty. And we might think the view from inside the tunnel is really nice and beautiful, but it's important to get out of the tunnel and see the beauty beyond the tunnel. So colonoscopy, if you really think back to first principles, it violates the first principles of what makes a sensible screening test. If you were to develop an ideal screening test, what would you want in terms of prep, invasiveness, sensitivity, risk of complications? And I can't even read my slide. Oh, and is it cheap? So you don't want to prep, you don't want it to be invasive. Yes, of course you want it to be sensitive. It should have no risk of complications. It should be cheap. God, I wish we had something like this. Well, there is such a thing. What about colonoscopy? No, it fails on almost every account. You need a prep, it's invasive. I'll grant you it's sensitive. It has risks of complications, as Jeff argued, although that does not sway the previous argument. And it's absolutely not cheap. So screening colonoscopy, really, I mean, how did we even get here? It was proposed, it's here. We don't have the data. So Here it is, no grade 1 level evidence. If you really want to practice evidence-based medicine, you have to go back to what has been proven. So FOBT, we know that works for incidence and mortality reduction, and you could potentially extend from there to fecal immunochemical testing. Flex-SIG, it's been proven to decrease incidence and mortality, and we do not have such data for colonoscopy. Now, great non-invasive screening is possible. So you might wonder, why has this lingered for so long? And I showed you this before, again, from Jeff Lee. Why would you ever do screening colonoscopy if you could set up a program, perhaps in a managed care way, perhaps in a managed care organization with population-based screening, maybe in Northern California? If one could do that, just imagine. Sensitivity 79% in one round. And if you say one round is just one round, what's the cumulative yield? Well, we have accumulating evidence, but also if you look at extrapolations from modeling, which I would argue for here are quite good, the differences between these hypothetical strategies are very, very small. You really have to argue very, very strongly that one should be doing screening colonoscopy instead of the non-invasive alternatives. And finally, I think this could be a big, big game changer. Blood tests are coming. I do have some disclosures here for advising, but if the blood tests pan out in the prospective studies anywhere near where the data seem to be in the initial studies, this is a big game changer. Very high sensitivities for cancer with very acceptable specificity and potentially quite good sensitivity by some of them, maybe, for advanced adenomas. So these prospective trials are going to be reporting out pretty soon, and they could really be game changers in terms of what we do in gastroenterology. So Jeff Lee wants to give you massive diarrhea with a PrEP. He wants to knock you out with sedation. He wants to stick a tube deep inside you. He wants to risk harming you, as he himself showed you with his own slides. And he wants to charge you tons of money. So don't let Jeff Lee keep using caveman methods. Vote Ladabaum for round 2 knockdown champion. I'm your Ladabaum, and I approve this message.
That was good. All right, ready for round 2 for the heavyweight battle. All right. So screening colonoscopy here to stay. Got to pay for my kids' college tuition. So clearly colonoscopy is the gold standard. I don't have to argue about that. We know that colonoscopy is the most effective test for reducing colorectal cancer incidence. I know we don't have level 1 evidence to be able to show that, but clearly there's high quality observational data sets that have been able to show that it is not only effective in reducing overall colorectal cancer incidence, but it's also effective in reducing both the right side and the left side of the colon. We also know that colonoscopy is very effective in preventing colorectal cancer deaths. And again, it's not only effective in the overall colon, it's also effective in the proximal colon too. And here's a study that was from Rebecca Siegel that we show that not only in our whole US population, which covers the SEER database, which covers the whole US population, we see that colorectal cancer mortality rates and incidence and mortality rates are declining. And we can see this is largely attributed to colonoscopy. Here on the right slide, you can see that the percentage of colonoscopy use or utilization has increased over the years. It's it's unlikely due to risk factors such as, last time I checked, I think we're all we enjoy meat. Other reasons that colonoscopy is king for now is that here from our Kaiser Permanente Northern California study, we were able to show that screening reduces colorectal cancer mortality by about 52%. And you can see as the curve continues to go up, what that is screening up to date. And we, as Kaiser Permanente, is well known for performing a fit outreach for every individual that's screening eligible. But what you don't see is the third graph right there, or the third in the squares. And that's colonoscopy use. Screening colonoscopy utilization was increasing up to 30% in our population. So this reduction in colorectal cancer mortality is largely attributed to both a programmatic approach with FIT and screening colonoscopy. We know here, based on a survey study and also a commercial claims database from MarketScan, that colonoscopy remains the most popular screening test here in the US, and we really don't see much waning from that. We also see that colonoscopy offers long-term protection. It's not only effective, but it's also durable in preventing you from developing colorectal cancer. And here are 4 observational studies that show nearly almost an 80% reduction at 10 years. Not only do we see that it reduces your risk of developing colon cancer, but we also see that it reduces your chances of dying from colorectal cancer at 10 years out, a nearly 80% reduction in terms of durability. Here's a study from the CONFIRM trial, which also shows that it's the gold standard for detecting polyps. And this was highlighted Jason Dominant's group out of the VA, showing that it's not only effective in reducing colorectal cancer, and this is mainly due to its ability to detect polyps, particularly advanced adenomas and serrated lesions. And when we talk about performance, we have to compare it with some of the tests that we were talking about earlier. FIT, how does it compare to Cologuard? And we can see that the sensitivity for FIT and Cologuard are inferior compared to colonoscopy. We see that the sensitivity for advanced adenomas is about 24%. The sensitivity for advanced adenomas for Cologuard is about 42%. Not only does it perform poorly for advanced adenomas, you can see it's pretty abysmal in terms of its performance in detecting advanced serrated lesions. FIT for the sensitivity is 5.1% for FIT and about 42% for Cologuard. And we know that colonoscopy continues to remain the most accurate screening test for detecting not only colorectal cancer, but for advanced neoplasia and also advanced serrated lesions compared to the blood test, the CT colonography, and even the capsule. Not only is it the ultimate test in detecting polyps, it's a one-stop shop. And we can see that these non-invasive tests are two-step tests, and it requires follow-up. And we can see here from 2 studies that the follow-up rates at federally qualified healthcare centers and even some healthcare groups are suboptimal, reaching up to 40 to 50% at certain centers after 12 months. And we know that the lack of follow-up has deadly consequences here in this Italian study, that after 10 years of follow-up, that the mortality risk is over 3-fold if you fail to follow up for a colonoscopy. Not only is these non-invasive tests perform poorly for detecting advanced neoplasia and advanced adenomas, but it requires a programmatic approach. So you have to do this yearly for FIT or serially for every 3 years for Cologuard. And we could see from this study from Jason Dominantz, who just summarized the data of 6 rounds of FIT, well, you see that the adherence to FIT declines every year. Even after 6 years, only 44% was actually adherent to FIT. And here in the Dutch study, we could see also the same pattern as here in the US, that adherence to 4 rounds of FIT was about 49%. And we in America, we love choice. And here's this study that choice matters. And this was a cluster randomized trial from the San Francisco General Hospital group. And this is a safety net hospital, and they randomized patients to FOBT, colonoscopy, or choice of colonoscopy or a choice between colonoscopy and FOBT. And the outcome of interest was screening adherence. And what they found was that participants assigned to FOBT completed screening at a lower rate over 3 years, 14% than those assigned to colonoscopy or choice. So choice matters. And lastly, colonoscopies remains cost-effective compared to these new developing non-invasive tests. And this is a study from our vice chief that's sitting, our 3-time champ right here, quoting that our results suggest that FIT and screening colonoscopy are cost-effective and less costly than our Cologuard tests. So the big reveal later. What did the 3-time champ select for his colorectal cancer screening test?
I don't know. That may remain a mystery forever. We'll see. I can answer. ADR is inadequate and should be replaced by alternative metrics. Absolutely, yes. You want a cleared colon. Quality matters. And there are multiple studies that show this. Here is just one of them showing that if you look at the relative rate, this is the standard incidence ratio of having colorectal cancer compared to the general population, as a function of time after you underwent colonoscopy. If you had a high quality colonoscopy, which is in the white, then your standardized incidence ratio remains very, very low for a long, long time. But if you had a low quality colonoscopy, not surprisingly, you start inching up towards the rates that you might see in the general population. And we know that the risk of having colorectal cancer after you get screened depends on what you have at baseline. Do you have no adenomas in the green? Do you have low risk adenomas? Do you have high risk adenomas? Well, this is only meaningful if you detect everything that's in the colon. And these data come from a certain researcher, J.K. Lee. You may see him around here. So you got to find everything. Now, you have to beware the one and done phenomenon. Shortly after adenoma detection rate was recommended as a metric, people said, well, but what about patients who have more than one lesion? And what you see here is that there are people who are in the right lower quadrant. They have a high adenoma detection rate, but they do not have a high, what was called in this study, ADR plus. Now you can think of it as adenomas per colonoscopy or total number of lesions per colonoscopy. You want to be in the right upper quadrant. You want to be high in both. You cannot be satisfied with just being a high adenoma detector and a low APC, adenoma per colonoscopy, or a low ADR plus person. That's the right lower quadrant, one and done. I don't think anybody does this intentionally, but busy day, you're scoping, you find an adenoma, boom, that ticks for my quality colonoscopy, maybe subconsciously you relax, you don't look at the folds that carefully, you're a one and done person, you leave behind an important lesion, and then you don't know where you are on the curve that Jeff Lee generated in the previous study. You got to beware the one and done. Any soccer fans out there will know there was a thrilling conclusion to the season a couple of weeks ago. Man City wins 3-2 with tremendous importance. What does Jeff want? He's going to argue for ADR, where 1 counts as much as 2, counts as much as 3. If Jeff Lee had his way, he would kill the thrill in sport. Look at this big meh. Greater than or equal to 1 versus greater than or equal to 1. Absolutely no excitement there. So Jeff, come on. ADR does not capture the cell-associated lesion detection rate or advanced adenoma detection rate. And both of these are very important. Now, from our own data at Stanford, ADR is on the x-axis, the y-axis is cell-associated lesion. There is an association, but it's very, very weak. People are all over the place. And it's even worse for advanced adenoma. There's really no good correlation here. Much larger sample size from the Polish colonoscopy screening program, where you look at the cloud in the top right, it's advanced adenoma on the x-axis, adenoma detection rate on the y-axis. They're all over the place. So ADR is really not enough. So now let's look at what is a proxy for the cell-associated lesion detection rate. And this is the proximal serrated polyp detection rate. So basically, this investigator said, we don't want to deal with the question of whether pathologists get it right or not. Proximal serrated polyps are probably cell-associated lesions. Let's see what happens to the adjusted hazards rate on the y-axis for colorectal cancer if you look at how good doctors are at detecting these lesions. So the higher and higher the quintile of detection, the lower and lower the rate of interval colorectal cancer. You've seen these curves before for adenoma detection. And so you may be wondering, are these two independent effects? And so what they did here is to plot on the x-axis adenoma detection rate, on the y-axis proximal serrated polyp detection rate. These rates are high. This is a fit positive screening population. So you'll see their ADRs, in the middle there, they're in the 60s. This is not screening colonoscopy. This is fit positive. But the top right quadrant, high adenoma detection, high proximal serrated polyp detection rate, that's a reference of 1. So you're high detector on both. If you look just to the left of that, those are low ADR people, high serrated, risk of 2-fold compared to the reference. If you're in the bottom left quadrant, you're low detector for both, risk of 2.55-fold for your patients. And then if you look at the right lower quadrant, you're a high adenoma detector, but you really don't see the serrated lesions. Risk is 1.8-fold. So these two give us independent information. Just measuring your ADR is not enough. You have to be a high detector in serrated lesions as well. Now, saying that it's hard to measure this, it's no excuse. I grant you it's hard, but it can be done. It took us many years at Stanford to build the system, but we now have one where if we do our colonoscopy reports a certain way, and then we use the pathology reports to generate a standardized letter to tell patients, this is what you had, this is what we recommend, and we send that to the patients and the referring docs, which is all standard work. So there's no double documentation here. It's just do your colonoscopy report and report your recommendations to patients in a standardized way. Then this flows through a standardized mechanism through a database. We can do quality audit. And with that, we can routinely generate all our metrics by all the indications: screening first, not first, surveillance post-polypectomy. And here we have the adenoma detection rate, advanced adenoma, CES ulcerated, advanced CES ulcerated. Those are all queryable, and we give all our docs their performance metrics. Now, I'll tell you later how I chose to be screened, but would you want to be scoped by you? Japanese investigator actually reported this years ago. This is real. He scoped himself. And by the way, George Trefilopoulos, who many of you know, told me he was the editor of GIE. And initially the reviewers were not enthusiastic. And he made a very kind recommendation. He said, why don't you guys draw a little cartoon? And then I think reviewers will like it. So they drew the cartoon and then it got accepted. So would you want to be scoped by you? The answer is yes. And if you were to scope yourself, I think you would want you to have not just a high ADR, but a high adenoma per colonoscopy detection rate, a high CES ulcerated lesion detection rate, and a high advanced adenoma detection rate. So Jeff Lee says ADR is enough. He condones a suboptimal quality colonoscopy for your mother. We have to stop Jeff Lee. So round 3, knockout champion. I'm Yuri Ladabaum, and I approve this message.
All right, if you guys want a refund after this, please look for Serge Gupta. Sorry to disappoint the third round, but let's see. Let's see if the community doc could overpower the 3-time champ. All right, so I'm gonna say that ADR is enough, essentially. So we all know that ADR is the most validated colonoscopy quality indicator. And so clearly there's been 2 to 3, actually 3 studies now have shown that it's an important metric in terms of reducing your patient's future risk of developing colorectal cancer and your patient's future risk of developing colorectal cancer mortality. And so I don't have to remind everyone in this audience right here. But we also see that ADR, there's wide variation, and it's perfect for quality improvement purposes. That's the whole purpose of this, is that we want to be able to measure it, and we want to be able to show that we can improve, and it ultimately impacts your patient's future risk of developing colorectal cancer and dying from colorectal cancer. And in fact, the Polish group did just that. Not only did they measure it, but they noticed that if you improved your ADR, you actually improved your ADR, it actually does truly impact your patient's future risk of developing colorectal cancer. Not only is we see incredible data showing that ADR is linked and associated with reducing colorectal cancer incidence and mortality, but we also see overwhelming support from all our GI societies supporting that ADR is the metric to measure. And it's also widely measured in clinical practice. Here we see our own our vice chief's institution here measuring ADR as a common practice in their group. So some of the criticisms that Dr. Ladabaum mentioned, the one and done phenomenon, and he mentioned something that came out of the VA. And so this was about 3,000 VA patients who underwent screening colonoscopy. This was actually performed at the West LA VA and other 3 private facilities. So they contracted out with these private groups to be able to help absorb some of the screening colonoscopy. What they found was this one and done phenomenon. And that's where you have a high ADR, but you actually are not looking for more than one. After you find that one adenoma, you kind of burn out a little bit, get a little tired. We don't know, but apparently that you don't actually find more. There's no additional adenomas that are actually recorded after that. So this one and done phenomenon. But I would like to propose to you, it's very uncommon in clinical practice. Stacy Fedewa was able to show you that they looked at 25,000 individuals who underwent a screening colonoscopy at the New Hampshire Colonoscopy Registry. And this was based out of 69 gastroenterologists. So if you look down at the bottom right, you clearly don't see that one and done effect in this group. And this was a much larger study. So this suggests that the one and done phenomenon is actually uncommon. Yuri also mentioned that, if you, ADR does not account for patients that, have serrated polyps. Of course it doesn't. Yes. And clearly we see that Joe Anderson's group is that it was able to show that sessile serrated polyps is linked to reducing your risk of dying, your risk of developing from colorectal cancer. So having an SSP or proximal hyperplastic polyp detection rate may be an important quality indicator. Dr. Ladabaum also mentioned that APC may be an important quality indicator of measure. And this is a study that was really recently published from the Polish group. So now we have 2 additional quality metrics that Dr. Ladabaum has really kind of emphasized that we should continue to report for not only for ourselves, but for our patients. But let's take it back a step, because there's just millions and we're actually getting bombarded with all these quality metrics every single day. When is enough? So if you go back to the National Quality Forum, which kind of comes up with all these quality metrics, there are 4 factors that identify a good quality metric. And let's just review that for the audience, because there's just, we as doctors, as healthcare systems are actually overburdened a lot by a lot of these quality metrics. So we could propose the sessile serrated detection rate. We can propose the APC detection rate. But let's take a look at these 4 factors. The first factor isn't important. Does it address a critical component in care? Does it affect the outcomes? I would agree that serrated detection rate may affect colorectal cancer outcomes. APC too. Is there room for improvement? I don't know. We haven't seen much data showing that. How about scientific acceptability? Is the metric reliable? Can it be corrupted? We see in the ADR that, perhaps there could be a one and done phenomenon. Well, actually, it's very uncommon. Could this SDR, serrated detection rate, be corrupted? Could the APC be corrupted? We'll talk about that in a little bit. How about feasibility? Is it easy to measure? Not everyone's Stanford University that's able to get every single doctor to follow the same template to be able to kind of report out. So how easy is it to measure adenomas per colonoscopy? Clearly, we don't see that being demonstrated even at Stanford University. Usability, is it acceptable to patients, payers, and even physicians? So let's talk about some of these limitations of the ADR, of APC and SDR. I apologize for that. So APC, it's incredibly challenging to measure accurately. You really need to require multiple jars and to put each adenoma in a jar to have an accurate measure in terms of adenomas per colonoscopy. And that will definitely increase costs, increase time. It's rarely used in clinical practice. And can it be gamed? Yes, you can. You can actually remove an adenoma in a piecemeal and put it in each jar to help game it. So there's all these weird, ways to be able to game some of these quality metrics. How about the sessile serrated polyp detection rate? We all know that it's highly, there's inter-observer variation among pathologists. So as a result, this really measures the pathologist's performance, not really the gastroenterologist's performance. And lastly, if you want to go for the proximal serrated detection rate or proximal hyperplastic rate, that can be gamed too. You essentially take a hyperplastic in the rectum and actually label it as proximal hyperplastic polyp. So that can certainly be corrupted too. So I want to mention, is the juice worth the squeeze? I would safely say, I would argue that ADR is highly correlated with APC or adenomas per colonoscopy. Here we see a really strong correlation. If you look at the correlation coefficient, it's like 0.9 to 0.97. That's nearly perfect in terms of ADR with APC. We also see it's strongly correlated with serrated detection rate. And so what that means is that if you have the ability to detect adenomas, you absolutely have the ability to detect another type of polyp, which is your serrated polyps, because you're using the same technical skills, the same cognitive skills to be able to detect these lesions. And lastly, I want to summarize something that Voltaire would say: perfect is the enemy of good. Why, defeat your ability to measure ADR with something that, can be equally corruptible. And we know that ADR is sufficient. It's easily measured. It can be improved. It's well validated. It's highly correlated with APC and SDR. It's widely endorsed by every single GI society. And the issue of one and done, incredibly uncommon, just one study.
Thank you, guys. That was